Please be seated. The Board of Inquiry into the Hazelwood mine fire is now in session.
The first witness this morning is Dr. Rosemary Lester, the Chief Health Officer. Her evidence will be followed by that of Professor Don Campbell, who's been retained by the inquiry to provide independent expert opinion. And the community witness this afternoon will be Annette Wheatland of Southern Cross Community Care. Would Dr. Lester please come forward?
Please state your full name.
My name is Rosemary Ann Lester.
Please repeat after me. I do solemnly and sincerely declare and affirm
I do solemnly and sincerely declare and affirm
that the evidence I shall give
that the evidence I shall give
to this Board of Inquiry
to this Board of Inquiry
will be the truth,
will be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Good morning, Dr. Lester. Welcome.
Thank you.
I'll start where I start with everyone else. Could you please state your full name and your professional address, please?
My full name is Rosemary Ann Lester.
And you are the Chief Health Officer?
That's correct.
Which is a statutory position created by the Public Health and Wellbeing Act.
That's correct.
You've made a statement to the inquiry.
Yes, I have.
And you have that there in 2 volumes in front of you. It's a statement of, just to be completely clear, 103 paragraphs with 22 attachments,
That's right.
Some of them voluminous. Have you reread your statement recently?
I have.
Is there any correction that you wish to make?
No corrections.
Is your statement true and correct?
It's true and correct.
I'll tend to that if I might.
46.
Dr. Lester, I'd like to ask a little bit about your own experience and background. You have provided us with a curriculum vitae, which is the first attachment to your statement. You're medically qualified,
That's
completed
right.
your studies
Yes.
in 1980, I think.
That's right.
You spent some time doing the residency, the standard
That's right.
course for a young doctor, and then you had a good solid period in general practice in the 1980s.
That's right. Yes.
From there, you took a different course, moved into the public service, and initially worked at the City of Melbourne.
That's right. Yes, I was Medical Officer of Health for the City of Melbourne.
And that was for several years in the late 1980s.
From 1986 to 1989.
And then you joined the Department of Health, and in its various with its various names over the years from 1989.
That's right. Yes.
You've held a range of positions in that organisation. Can you talk us through your progression through the Department of Health?
Sure. Well, I entered the Department of Health through the Victorian Public Health Training Scheme, which was a 2-year rotational scheme to provide practical experience in public health. You will see from my CV that prior to that, or actually just as I was entering, I was doing a Master of Public Health through Monash University, and the Victorian Public Health Training Scheme was designed to be a practical complement to the academic studies in public health. So once I completed that 2-year public health training scheme, I then continued on full-time employment in the department, initially as a medical officer within the communicable diseases section, where I worked mainly on notifiable diseases and immunisation. I then spent several years as immunisation coordinator, so responsible for the state immunisation program. Then the next position I went to had a range of responsibilities, including cancer screening programs, the genetics programs, perinatal data collection unit. So I had a range of experience there before coming back to being Assistant Director of the Communicable Disease Control Unit, and from there progressing to Deputy Chief Health Officer and now Chief Health Officer.
And during that time when you were Manager Prevention and Perinatal Health, you actually worked with Professor Catford in the Department of Health for a while.
I did, yes.
In fact, worked for him for a while.
I did work for Professor Catford for a while.
Now, as well as as all of those roles in the Department of Health, you've referred to some postgraduate qualifications that you obtained. The first of those was a Master's in Public Health that you obtained from Monash University.
That's right.
And there is another Master's degree that you also completed through the University of California, Los Angeles.
That's correct.
And that's a Master of Science in Epidemiology.
Yes.
For those of us with a loose grip on it, can you explain what epidemiology is?
Epidemiology is the study of the distribution and determinants of disease in populations. So it's the science of looking at health on a population basis, both health outcomes, health risk factors, and evaluation of public health programs.
Moving then to your role as Chief Health Officer.
Sorry, could I perhaps just add to that my fellowship of the Australasian Faculty of Public Health Medicine? Mm-hmm. So I am recognised as a specialist in public health medicine.
So that's a discrete area of medicine.
That's right. It's, again, like epidemiology, it concentrates on the health of populations as opposed to individual clinical health.
Right, now we'll move to your role as the Chief Health Officer. It's a statutory role, and the Public Health and Wellbeing Act is a fairly compendious act. There's a lot covered in it, but your functions and powers are set out in section, I think it's 21, after the role of the Secretary. And the principle, or the first in the list, is to develop and implement strategies to promote and protect public health and wellbeing. That's a fairly broad remit.
That's right.
You have a role to provide advice to the Minister or the Secretary on matters relating to public health. There's an obligation to publish a public health and wellbeing report every 2 years.
That's right.
And then there's the usual anything that's incidental or any other responsibilities that are given.
That's right.
But it's principally a role to develop and implement strategies to improve public health.
That's right.
There are some principles set out at the beginning of the Public Health and Wellbeing Act that are designed to guide the performance by everyone who has a position or a responsibility under that Act. And these are reasonably familiar because a similar set of principles appears in the Environment Protection Act. They are the principle of evidence-based decision-making, the precautionary principle that I discussed with Mr Merritt on Monday morning, the primacy of prevention, principle of accountability, and the principle of proportionality. So a public health response should be proportionate to the risk, and the principle of collaboration. I'd like to dwell a little bit on the precautionary principle. The Act states that the principle to guide action is if a public health risk poses a serious threat, lack of full scientific certainty should not be used as a reason for postponing measures to prevent or control the public health risk.
That's right.
How do you apply that precautionary principle in practice?
Well, I think it's a matter of balancing the risks that we see and balancing the sorts of interventions that we might put in place. So it's very important from the start of any particular public health risk that we consider carefully the magnitude of what that risk might pose, and then we consider carefully what the outcomes or the implications of any public health intervention we might put in place. If I could take an example of perhaps, say, a foodborne disease outbreak, where we might suspect a particular product of being the source of that foodborne outbreak. If we suspect that and we have what we believe is sufficient evidence to act, then on the precautionary principle, we say, okay, we believe we've got enough evidence to act, even though it might not meet full scientific certainty.
Now, we looked yesterday with Professor Brooke at an organisational chart of the Department of Health. I just want to ask you a few questions about where you fit within the Department of Health. I think we saw where you fit within the organisational structure, You report through a Deputy Secretary to the Secretary. Within your own office, what staff do you have?
Well, as you saw on the organisational chart.
We can bring it up again if it would assist, I think.
Okay.
It was tendered as part of Professor Brooks' statement.
That's right.
Yeah?
So you will see that I sit alongside the Health Protection branch. Yes, I sit. Health Protection is the second light blue box there, and I'm immediately under it. So the way that my office is structured is that I have 3 small programs who report directly to me. I also have the public health medical expertise in my office, which I use to supplement the staff in the other various health protection units. So I have 3 senior medical advisors, one of whom is my deputy, and then I have 2 more junior public health medical officers. So I work, although I appear separate from the health protection branch, on a day-to-day basis, both me and my staff work very closely with the other health protection branches. You heard Professor Brooke yesterday talk about the environmental health branch, which has 8.9 EFT. One of my senior medical advisors plus one of the junior public health medical officers is assigned to work with the environmental health branch to supplement their workforce. So I do the same with all of the other units in health protection. So the TB unit, Legionella control, communicable diseases, immunisation, food safety. I'm working on a day-to-day basis with those, and my staff are working on a day-to-day basis with the staff in those units so that we form an integrated team.
All right, so just to be clear about the environmental health support that's available to you, because that was the relevant expertise in this instance.
That's right.
There are almost 9
Yes.
Staff in the health protection area.
That's right, yes.
And do they work as a unit?
They work as a unit, that's right.
And their expertise is available to you?
As I said, I work with them on a day-to-day basis.
And in addition, you have a medical advisor who also works on environmental health matters with the environmental health team.
That's correct.
Have I understood that correctly?
Yes, that's correct.
Just to get an idea of the size of the people in your office, I think I understood you to say you had 5 medical advisors reporting to you.
That's right, I do.
Okay. And in addition to which you have assistance from the health protection team.
That's
when
right.
needed.
Yes.
In terms of communications support, where do we find that? Communication being a fairly significant part of your role.
That's right. Well, I do have a small communications team that reports directly to me, and that consists of a manager, 2 full-time staff and 1 part-time staff. But the department, as you heard Professor Brooks say yesterday, has a shared service for emergency management between ourselves and the Department of Human Services. So that also has a communication function. So my communication staff obviously work extremely closely with the communication staff from the shared service. And then, of course, in an incident such as this, there's the whole of government coordination of communication.
All right. But you have a dedicated communications staff within your
I do,
office?
yes.
Now, in addition to your role under the Public Health and Wellbeing Act, there's also emergency management, with which we're concerned here. Do I understand correctly that you have no statutory role under the statutory emergency management arrangements?
Under the Public Health and Wellbeing Act, I have a range of public health risk powers. So I'm able to exercise powers in order to investigate, eliminate or reduce a risk to public health.
Right.
If an incident is of such magnitude that it would be classified as a public health emergency, that is a decision that I advise the Minister on, and the Minister is required to discuss that with the Minister for Police and Emergency Services and the Chief Commissioner of Police. So the actual declaration of a state of emergency, if that was required, goes through that mechanism. Once that's been declared, then I have particular public health emergency powers which are able to be then exercised.
All right. So when we look at the emergency management manual, there's actually no mention of the Chief Health Officer.
That's right.
In that section that explains the roles of the different agencies. The Department of Health is designated the control agency for health emergencies, to use a broad term.
Yes.
And then there is an internal document within the Department of Health, the Public Health Control Plan.
That's right.
That designates you as the incident controller for those emergencies.
That's right.
And I take it that's because of the statutory powers you have in relation to a public health emergency under the Public Health and Wellbeing Act.
That's right.
All
yes.
right. But we're not dealing with that kind of emergency here. We're dealing with a fire. So it's your support functions that are important in this instance.
That's right.
Now, again, there's no specific role given to the Chief Health Officer in the Emergency Management Manual where the Department of Health is a support agency. Is that correct?
No, there's no specific mention there.
But there is clearly a role when it comes to relief and recovery to provide advice to the incident controller and to other support agencies involved.
Well, it's more than relief and recovery. It's my role is to provide public health advice on any incident to the relevant incident controller. So, as in this instance, I would do that from the start of an incident and not just confine my advice to relief and recovery.
That's not spelled out, however, in the Emergency Management Manual, is it? It might help to look at it. If we can look at attachment 2 to Dr. Lester's statement. And if we go to page 7-36. If it helps yes, that's the page. All right. So under the heading response, the Department of Health is the control agency for the health emergencies that we've identified. And then as I read the remainder of those dot points, it's about the State Health Emergency Response Plan and ensuring that health services are available to meet the health needs that are caused by any particular emergency. And there's nothing in there about provision of public health advice, is there?
No, there isn't, but that's in practice the role that I play.
But we do see at the very last dot point on the page, under relief and recovery, provide advice, information and assistance to affected individuals, communities, funded agencies and municipal councils. And that's what you were doing in the course of this incident, is it not?
That's correct,
Right.
yes.
Can I ask you now about the bushfire smoke protocol, which is a document that you've attached as attachment 5, and you refer to it in paragraph 19 and 20 of your statement. This is a document that was developed after the 2006-2007 Alpine bushfires.
That's right, about that time.
Yes, and they burned for weeks and weeks and weeks, and at various times during that period there were heavy areas of smoke over settled areas of Victoria, including Melbourne, but also elsewhere. And that incident was the prompt to develop this bushfire smoke protocol. Have I understood that?
I understand that. I wasn't in this role at that time, so I wasn't involved in the Environmental Health Unit at that time, but that's my understanding, yes.
All right. Can you explain how the protocol works in practice? We have some tables that inform a level of response. There's table 1 at page 11 of the document.
So this is the agreed protocol that we have with the Environment Protection Authority, which means that we have agreed actions and agreed health messages prior to the summer season. So we're not trying to think of messages when an incident occurs.
Yes.
So the table here provides us with information as to, according to what the EPA either measures or predicts is going to happen, that results in either a low-level smoke advisory put out through a media release, or a high-level smoke advisory put out through a media release. And those media releases contain messages from me as to what people need to do to protect their health. Given that we know that bushfire smoke can have acute health effects on health effects, then we need to get the message out from the start as to what people need to do to protect their health.
All right. Now, the protocol is based on air quality categories that are determined principally by PM10 measurement.
That's right.
And the PM10 standard in the State Environment Protection Protocol for ambient air quality is 50 micrograms per cubic metre.
That's right.
Over a 24-hour period. And so we see that the low-level smoke, the low level kicks in once levels exceed 50 micrograms per cubic metre. I understand that this document was developed before you came into the position, but are you able to say why PM10 is used rather than PM2.5 as the measure?
My understanding is that the vast majority of the monitoring which the EPA does, well, the vast majority of the monitoring which they do is PM10.
Right.
So hence this is based on PM10.
So the protocol's tailored to the monitoring that's readily available.
That's right. And we know what the health effects of PM10 are. In more recent years, a better understanding has come of the health effects of PM2.5, but PM10 has been the standard for looking at health effects up until sort of recent years.
Right. And then it's immediately noticeable on this table that there's one low category, but there are three high categories, all of them the same colour. Everything in excess of 155 micrograms over a 24-hour period is designated high. Do I understand correctly that the action that is taken under this protocol doesn't vary between the different levels of high?
That's right. The messages are the same for those levels of high.
All right.
That's right.
Which then prompts the question, why have three levels if the action is always the same? And the action is to issue a high-level smoke advisory.
Sure. It's important to remember that this protocol is designed for a relatively short-term event, such as a bushfire, which usually only lasts for maybe a few days or a week, close to a community. So it's felt that although we have those internal classification levels, that it's important to keep the message as simple and understandable as possible for the community, which is why for this protocol, which is written for a short-term event, and these messages are being issued day by day, that it's important to keep those as simple and understandable as possible. Because even though we do have those internal classifications, the actions that people need to take to protect their health are the same.
Do they not vary as the levels of fine particulate matter in the air increases?
Well, as I mentioned, this is designed for a relatively short-term event.
Yes.
What we know is that particulate matter can have effects on health, so it can exacerbate both cardiac and respiratory disease. It can also have the short-term irritant effects, which are obviously very distressing, irritation to the nose, eyes, respiratory tract, headaches, and those things are obviously very distressing. But what is of more concern to us is the fact that bushfire smoke can exacerbate cardiac and respiratory disease. So the message that we need to give for when there's a high level of smoke in the air is for not only those in the most vulnerable groups, which we primarily direct our message to, but for everyone to avoid or reduce outdoor physical activity as much as possible. So again, we're trying to keep the message simple and straightforward and understandable to the community.
All right, and just to look at the message, if we look at page 22 of the document, that's the template for a high-level bushfire smoke advisory. Has some quotes from you that I gather are pre-authorised quotes.
That's correct.
And this is a document that'll be familiar to anyone who was keeping an eye on the EPA's alerts during the Hazelwood mine fire.
That's correct. Yes, the first of these was issued on the 11th of February, and they were issued very regularly after that.
Yes, and they really didn't change in their content, did they?
No.
No, the only variation was between the low level and the high level.
That's right.
And the advice that is given about precautions that might be taken is really that people should avoid prolonged or heavy physical activity.
That's right, yes.
And otherwise, people should take their medication and consult their doctor.
That's right.
So there's no advice in here that people are best avoiding inhaling smoke altogether.
Well, the advice to avoid prolonged or physical activity, yes, is designed for people to minimise exposure to their smoke, their exposure to smoke.
Yes, but there's no advice in this that people should, for example, stay indoors, or if possible, take a break out of the area that's affected by smoke, or, given the likely duration of the event, to consider leaving the area for a period.
Those more detailed messages are available on our information that we have on our website, and those more detailed messages that you've mentioned, I always quote in any media interviews that I do about smoke. So again, it's a matter of keeping the basic messages as basic and understandable as possible.
Could I just say, I think Table 2 is helpful here because there is some variation according to severity or vulnerable groups. And
if we
look
look
there's an escalating scenario there.
If we look at page 12, Table 2, there is escalating cautionary health advice in the various high, very high and very, very high categories. But that's not reflected in the high-level smoke advisory, is it?
No, but it is reflected in, as I said, the messages that we have on our website, and those are the messages that I always use in any public comment about smoke.
Is there any reason why the high-level smoke advisory could not be tailored to actually reflect the cautionary health advice that's set out in this table?
We could certainly review the wording of that.
So that when the PM10 levels are predicted to be in the hazardous category, that the advice actually includes advice that people in vulnerable groups should remain indoors.
We could certainly look at reviewing that wording.
Just ask another question. Now, just note that in Table 1, PM10 for 1 hour is also a trigger. Just explain to us why you have a 1 hour trigger and also a 24-hour trigger.
Those levels are the standards which are regarded as well, as the unhealthy or the hazardous. So you obviously got a lower level for 25 hours as opposed to 1 hour. So it's really just a set of levels And according to the prediction that we receive from the EPA, which is again based on information from the Bureau of Meteorology, then they will advise us that they think PM10 is going to be elevated for 24 hours or PM10 is going to be elevated for an hour or a shorter period of time.
In section E of your statement, you set out some information about brown coal fires and brown coal smoke. And at paragraph 31, you make a comparison between the composition of smoke from a brown coal fire and the composition of smoke from a bushfire. The differences between the two are these, are they not? That carbon monoxide is present in higher levels from brown coal smoke.
Yes.
And polycyclic aromatic hydrocarbons and also volatile organic compounds are present in coal smoke, brown coal smoke, in a way that you don't find in bushfire smoke.
Well, they'll be present in any smoke. But yes, they're a concern in coal mine fire smoke.
Yeah, so they're the two distinguishing features of brown coal smoke as compared to bushfire smoke.
Well, there's also a distinguishing feature between the brown coal found in the Latrobe Valley, in that the brown coal found in the Latrobe Valley is different to other brown coal, and it produces different sort of smoke from bushfire smoke, in that it has actually lower levels of key pollutants such as nitrogen and sulphur. So you actually have lower levels of the nitrogen oxides and the sulphur oxides in the brown coal found in the Latrobe Valley than you do in other sorts of smoke.
Yes, so at least we didn't have a risk of acid rain during
That's correct.
During the mine fire. That's something to be glad for. But those are the two things that set aside brown coal smoke from bushfire smoke. The carbon monoxide levels are higher, and there is a greater need to be concerned about PAHs and VOCs.
Yeah, certainly it's something we need to take account of, but we know that the major health effects on smoke that we need to be concerned about are carbon monoxide and particulate matter.
Yes.
So they're the two top line things that we know we need to be immediately concerned about.
Yes. And of course another difference between a brown coal fire and a bushfire is that a brown coal fire can go on for a great deal longer than a bushfire.
Well, that's right, as unfortunately we saw in this event.
Yes, so
although
it's not a case
you did
of...
mention that previously there have been unfortunately bushfires which have gone on for a long time.
Yes, but with the brown coal fire, the fuel is not exhausted nearly as quickly.
That's right.
As is usually the case with the bushfire.
That's right.
You set out at paragraph 32 a number of variables that will influence the public health effects of exposure to a brown coal fire. Now, do I take it that these are all related to exposure to fine particles and don't include the separate risk of carbon monoxide exposure?
The carbon monoxide exposure is more of an acute toxic exposure. The particulate matter exposure is more something that we'd be concerned about the longer it goes on. Mm-hmm. So the particulate matter exposure is, we're not only concerned about the height, the level of the exposure, but then the length of time that people spend exposed to the smoke. Of course, that is the same for carbon monoxide as well, but carbon monoxide tends to be more acutely toxic.
Yes.
So these sorts of variables really relate to any of the pollutants in smoke. So of course, any of the pollutants are related to the size of the fire, or the level of fine particles obviously relates to fine particles, the known effects to the body, etc. So it really relates to any of the pollutants in the smoke.
All right, but there are these two separate risks that have to be recognised, and they do have slightly well, they have different sets of considerations around them, fine particles and carbon monoxide.
That's right, yes.
We've had some evidence over the last couple of days about ambient air quality standards. And just to recap on some of that evidence, the ambient air quality standards in Victoria are based on the National Environment Protection Measures.
That's right.
And those in turn are based on epidemiological research and are set at levels that are understood to be referable to adverse health effects.
That's right. They're set in exactly the way you've said, but with reference to a longer period of exposure, so with reference to continuing exposure. So the standards also allow for particular exceedances per year, which relate to the fact that there are going to be bushfires, there are going to be events which are uncontrollable, which will lead to poorer air quality for some days in the year.
So just to be clear about what those exceedances are, Mr Merritt provided us with the state environment protection policies. The relevant one is at attachment 7 to his statement. And you're going to ask me what paragraph he referred to it in.
Thank you.
Paragraph 68, if you go to that on page 12.
I don't think I haven't got the right. I'll look at it on the screen.
All right, and if we can go to the 6th page. And go to Schedule 2 at the bottom of that page.
Oh, yes, I have it now.
Okay. All right. So the allowable exceedances we see in the 5th column.
Yes.
So for carbon monoxide, the allowable exceedance, because there's only one, is 1 day per year.
Yes.
So the goal is that the level of 9 parts per million over an 8-hour period would only be exceeded once in a year.
That's right, that's the goal.
Now, we don't find in this table PM 2.5, but we do find PM 2.10. And the goal for PM 10 is that that level of 5 micrograms per cubic metre not be exceeded in more than 5 days in a year.
That's right.
And of course, the other measure of particulate matter is visibility reduction, and that distance of 20 kilometres not be exceeded in more than 3 days a year.
That's right.
All right. So, although they are set for with a long-term view, the number of exceedances that are allowed under this standard is quite small.
That's right, it is.
Now, I don't think we have a number of exceedances for particles as PM 2.5 because the goal is to take measurements with a view to setting a standard.
That's right.
All right.
I suppose just to add to that, of course, that as other witnesses have told you, that the Hazelwood coal mine fire obviously was a very complex and almost unique event in its scale and magnitude. So the exceedances are written for usual conditions. I think something of the scale and magnitude of this is, as you've heard from other witnesses, is really quite complex and unique.
But clearly, we were well in excess of the allowable exceedances on all of these measures.
Yes, we're in excess of those.
Yeah.
That's right.
And the ambient air quality standards, having been set by reference to the best available epidemiological research, are a very good guide to what to decisions and advice that should be given in relation to public health, are they not?
That's right, because they are based on evidence as to the health effects of smoke.
We've had evidence over the last couple of days about the fact that there's only an advisory standard at this stage for PM 2.5. Mr Merritt's evidence was that one of the difficulties in setting a mandatory standard is that scientists cannot agree on a safe level. And you heard the evidence yesterday, I believe, of Dr Torre and Ms Richardson, who were agreed that there is in fact no safe level of exposure to PM 2.5. Do you agree with that evidence?
My understanding of the reason why there hasn't been agreement is not actually that there hasn't been scientific agreement. I don't believe that that's correct. Yes, my understanding of the evidence is that there is no safe level of PM 2.5, that health effects are seen under the various standards that have been set. But of course, nothing in life is without risk, and in the perfect world we would have no particulate matter in the air, but we're not in a perfect world, and there has to be some setting of levels which are achievable, both economically, feasibly achievable, having regard to the best health outcomes that we can take.
All right, so we also had evidence from Ms Richardson yesterday about levels that have been adopted in other countries that are significantly higher than the advisory standard. And it's a fair conclusion to draw that those levels are driven by what's achievable in the conditions prevailing in those countries. For example, China, I think the level was 75 as opposed to 25 micrograms. So there's a compromise to be struck between the accepted scientific view that there's no safe level and the need to set a level that is achievable and achieves good health outcomes.
That's right, yes.
In returning to your statement, if we can put aside Mr Merritt's statement for the moment, you discuss, starting at paragraph 36, short-term and long-term health effects of exposure to smoke and ash. And I'd like to understand what you mean by short-term and what you mean by long-term.
What we know from the short-term health effects of smoke is that I put them into two categories. So firstly, there's the short-term health effects which come from the irritation, so the surface irritation of the eyes, nose, throat, breathing passages, which can make people feel very uncomfortable and very distressed. But the other category that we're concerned about is particularly the exacerbation of heart and lung disease, so that we know that exposure to particulate matter increases the risk of people getting exacerbations of heart and lung disease, and in particularly those vulnerable groups that we've listed throughout all of our advice. So there's those two categories of short-term effects that I look at.
All right, so there's short-term effects and long-term effects. And before I leave short-term effects, I should just ask you this. There's been some evidence, and certainly the submissions that boards received reflect this, of people experiencing nosebleeds during the time that they were breathing in smoke. Is that a short-term health effect that is associated with smoke inhalation?
Well, I hadn't heard that. I mean, I've had that reported by the community to me. It hasn't particularly featured, but I think that is just an effect of irritation of the nasal passages from smoke.
Yes.
Obviously a very distressing thing to happen.
Yes. All right, so short-term health effects and long-term health effects you've discussed. Short-term
no,
exposure...
sorry, I haven't discussed long-term health effects. I discussed two types of short-term health effects. Long-term health effects are well described in relation to long-term exposure to particulate matter. So what I've described is two categories of short-term health effects that are well known and well described from short-term exposures to bushfire smoke or other smoke. What's well described in the literature is long-term health effects, and they include respiratory disease, cardiac disease, some sorts of cancers, some effects on birth weights of babies, and the literature is virtually confined to long-term exposure. So the literature on that basically comes from exposures which are usually listed as a year or more.
Yes.
So it's basically living in a polluted city.
Yes.
We know what living in a very polluted city for a long time, we know that those effects will happen.
So long-term exposure, 1 year or more. Short-term exposure, a day or a week.
It's usually described in the literature as days to weeks.
And the exposure in this case didn't really fit comfortably in either category, did it?
That's right. It didn't fit comfortably in either category, and that's why we've acknowledged, and other witnesses have said, that there is a gap in the literature about the sort of exposure that we saw that didn't fit neatly into short term. So there is a gap there, and that's what we've acknowledged by saying we'll undertake a long-term health study. I did say consistently through the event that because we don't have any evidence that short-term exposures result in long-term health effects, that we would not expect to see long-term health effects from this exposure, given that short-term health effects in the literature are described as days to weeks. So we would not expect to see it, but of course we cannot be sure about that. And the community are obviously very concerned about that. We would be very concerned if we did see long-term health effects. So that's why we've committed to the long-term health study.
But it's the case, isn't it, that the dose-response relationship between exposure to fine particles and the long-term health effects that you've described is not well understood?
We know that the body will recover from exposure to high levels of fine particles, which then go away. As I said, will produce short-term health effects, but the body will recover well when that exposure goes away.
That's not quite the question I asked. I'm asking you about the longer-term health effects that you've described. The dose-response relationship is not well understood. It's not clear how much or how long exposure is likely to increase cardiac disease, lung disease, the other longer-term health effects, cancer that you've identified.
Well, for long-term health effects, as I've said, the literature describes them from long-term exposures.
Yes.
So it is understood that the higher the level of particulate
Yes.
matter, the greater the risk of long-term health effects.
So the higher the level and the longer the exposure, the greater the risk.
That's right.
Yes. And there's no clear dividing line between a short-term exposure and a long-term exposure.
Well, there is in the literature. As I said, we don't have good literature in the middle. We have good literature on short-term exposures, which is, as I've said, are days to weeks, as described in the literature. And we have good literature on long-term health effects from long-term exposures.
But the literature in the middle that might inform where the dividing line is, just there isn't any.
Yes, there's a gap there.
At paragraph 40, you identify a number of groups who are particularly vulnerable to exposure from smoke from a brown coal fire. Could you talk through each of those groups and explain the particular reasons why each of them is vulnerable?
Well, I think it is explained there in my witness statement that if we talk about young children, firstly their lungs are developing and they have a higher respiration rate, so a higher breathing rate relevant to their body weight. So they're going to take in more smoke and therefore more particulate matter relative to adults. The elderly, which we usually describe as people over...
Just before you move away from children,
sure.
That susceptibility gradually reduces as the child grows.
That's right, yes, as they become more like adults.
So a 3-year-old will be more susceptible than an 11-year-old, for example.
That's right, yes.
But again, there's no clear dividing line.
There's no clear dividing line, no.
Sorry, I interrupted you.
That's okay. So older people will have a decreased reserve of their heart and lungs. So any strain that's put on that by breathing in fine particles will increase their risk relative to a younger, healthy adult.
Right, and in your advisories, you identified 65 as the age at which people enter that vulnerable group. Am I right in understanding that vulnerability, generally speaking, increases with age?
Yes, I mean the 65 is obviously a relatively arbitrary level.
Yes, we all know some very fit 65-year-olds.
We do know some very fit 65-year-olds. And obviously there are some very fit 80-year-olds and some very unwell 67-year-olds. So it is arbitrary, or relatively arbitrary. And of course it relates to the next point, which is people who have existing heart or lung disease. And as you get into the older ages, the more likely you are to have existing heart or lung disease.
And then there's a separate group of vulnerable unborn babies.
Yes, there is now emerging evidence that, although it's not regarded as yet totally causal, that exposure to fine particles over one of the trimesters, which is a 3-month period, may result in low birth weight in babies.
Right, now, when it comes to exposure to carbon monoxide, do we have the same vulnerable groups for similar reasons?
If you have high enough levels of carbon monoxide, that will be acutely toxic to everyone.
Yes.
But again, these groups still will apply. Carbon monoxide, as you will have read, displaces oxygen as it's carried around the body. So for people, say older people or people with chronic heart or lung disease, they are less able to cope with an insult of that kind.
And again, children, because they have higher respiratory rate, they're more likely to be active outdoors.
That's right, they're going to take in more.
Are going to take in more and reach harmful COHB levels sooner than a fit adult.
Yes.
Professor Campbell suggests in his report that a separate group can be identified, people of lower socioeconomic status, as being, as a group, more vulnerable to the effects of both fine particles and carbon monoxide. Do you agree with that proposition?
I personally haven't seen that proposition. We do know that people in lower socioeconomic groups unfortunately tend to have more chronic diseases, so it may well relate to that.
All right. So moving to this fire, the fire that started in the Hazelwood mine on the 9th of February, I understand from your statement at paragraph 42 that you became aware of the fire for the first time on the 10th of February.
That's correct.
And you were immediately concerned that fine particles from the smoke would pose the greatest public health risk.
That's correct.
But at that time, carbon monoxide hadn't registered as a particular risk for you.
No, we're aware, of course, that carbon monoxide was a hazard from brown coal fires. So it was both carbon monoxide and particulate matter that we were concerned about from early on.
You then say that you took some steps to obtain air quality information from the EPA.
That's correct.
And we've heard evidence from the EPA about how they went about obtaining that. While that was happening, the seriousness of the fire was assessed and appreciated at state level. Would you agree with that?
Well, again, I think, as you've heard from other witnesses, that there were many fires in the landscape in Gippsland during that first week. There were many fires which ignited on that weekend of the 8th and 9th. And those fires progressively were brought under control in that week, as I understand from Commissioner Lapsley. there was a material change, again as I'm advised, there was a material change in the fire on the weekend of the 15th and 16th, which really brought that into prominence as the hazard that we needed to deal with.
Well,
but remember
I'd like to suggest to you that the seriousness of the fire was appreciated earlier than that. Are you a member of the State Emergency Management Team?
I am,
Yes. And did you participate in meetings of that group during the week commencing the 10th of February?
I did, yes.
One of the pieces of information that is presented at those meetings is a State Control Centre situational report.
That's right, yes.
And there were reports presented from the 12th of February that identified that the Hazelwood mine fire would burn for up to a month.
Yes, I remember seeing that statement there. I think it's fair to say that there were varying estimates after that statement was in that situation report, that there were then varying estimates of how long the Hazelwood fire would burn, and there was some optimism followed by some pessimism.
Well,
so throughout
Commissioner Lapsley's evidence was that from the 12th of February, the estimate at the State Control Centre and for those involved in the State Emergency Management Team was that the fire would burn for up to a month, and that while he may have been more optimistic in his public statements, he considered that 1 month was the estimate that held, and it turned out to be quite accurate.
That did turn out to be accurate.
Did you have separate discussions with Commissioner Lapsley about the likely duration of the fire?
I don't recall specific discussions with him. Our focus during this first week of the fire was making sure that we got the messages to the community about the hazard, which was primarily carbon monoxide and particulate matter. And that hazard, as you've heard described, is the same for bushfire smoke as for coal mine smoke. So whether it was the bushfire smoke, which we know there was a lot of smoke around, or smoke from the coal mine, which was obviously mixing with it, the major hazards were carbon monoxide and particulate matter. And the messages that we had in our pre-agreed protocol with the Environment Protection Authority were the messages that we needed to get to the community so that they knew what to do to protect their health,
well,
whether it be from the bushfire smoke or whether it be from the coal mine smoke.
Those messages are the ones that we looked at earlier.
That's right.
Under the bushfire smoke protocol.
Yes.
Say nothing about carbon monoxide, do they?
They don't say anything about carbon monoxide, but nor do they say anything about particulate matter. I don't think it would be particularly helpful in public messages to discuss those things. What we need to put in public messages is what do you need to do to protect your health? What's the information that you need to know how to protect your health?
Yes, and the advice that was provided was avoid physical activity outdoors, and if you have asthma or if you have a pre-existing condition, take your medication and consult your doctor.
In those media releases, that's correct. There were many other communication activities which began on the 11th of February, and if I would take you to attachment...
I actually don't want to go there at the moment.
Okay.
What I'm trying to understand at this point is your appreciation of the likely duration of the fire. Commissioner Lapsley has given evidence that from at least the 12th of February it was understood at state level that the fire was likely to burn for up to a month, although he confessed to being more optimistic in some of his media interviews. Was that your understanding from the 12th of February, that it was likely to burn for up to a month?
Well, that statement was made, and as I said, the information that I heard Commissioner Lapsley say, and as you've said in media interviews, was that there was varying levels of optimism at times as to perhaps it could be put out earlier, and then unfortunately setbacks from that.
All right, so you were aware of the situation report estimate that it would likely burn for up to a month?
That's right, yes.
You were also aware of some more optimistic estimates?
That's right.
Perhaps 2 weeks?
Yes.
Did you seek clarification from Commissioner Lapsley about which was the more likely duration?
Not specifically, no.
It's a fairly critical piece of information, was it not, Dr. Lester? How likely the fire was likely to burn? How long the fire was likely to burn?
I was involved in the I was involved in the state emergency management team as time went on, so I was continually discussing the fire at that level as the state emergency management team. But what I needed to do was to assess the immediate hazard. So there were two parts to that immediate hazard that I needed to address. And the first was the carbon monoxide level, and the second was the exposure to particulate matter. So in those early days, the duration of the fire whatever duration of the fire was going to take would not have changed the messages that I had to put out in those early days.
But given that the risk to health increases with the duration of exposure, surely the likely duration of the fire was the critical consideration for you in that first week.
The exposure to fine particles, as I said, we know that it causes acute health effects, and we know that the body recovers quickly after the level of fine particles falls. So what we needed to do was act on the advice we were given from the Environment Protection Authority. Prior to that, we acted on general advice about what we knew about particulate matter. We needed to act on advice from the Environment Protection Authority as to what the particulate matter was. And we were keeping a very close eye on that as day by day we were keeping a very close eye on that as to what our advice should be to the community.
Did you, during the first week, make an assessment of the likely duration of the fire in the mine?
Not in that first week, because the advice we needed to give was predicated on what are the levels at the moment.
You have... Your evidence is that the risk increases with the duration of exposure.
That's correct.
Yes. So it's important to understand the likely duration of exposure at an early stage, is it not?
That's correct, but that's what we do through monitoring.
That's going to guide the advice that you give the public about.
That's right. That's what we need to monitor day by day.
Right, but in the first week, I understand your evidence to be that you did not make an assessment of the likely duration of the fire.
Well, I was present at many of the State Emergency Management Team meetings where the duration of the fire was discussed.
And the advice that is recorded in the documents is that the fire was likely to burn for up to 1 month.
That's correct, but I would come back to the fact that the advice we needed to give to the public was based on the level of pollution that we saw in the air at the time.
And
we're assessing our advice day by day based on that exposure.
So you were providing advice on a day-by-day basis?
Yes. Rather
than, in that first week, assessing the likely duration of the entire event?
Yes, because although, as you'll see from the air quality charts, although the fire burnt for quite a long time, the air quality was very variable during that time. So it's not reasonable to say, well, the fire will burn for a month and therefore the air quality will be equally bad for a month. The air quality varied quite significantly throughout the duration of the fire.
Yes, but the duration of the fire was one critical piece of information, because until the fire was out, the smoke wasn't going to clear, was it?
That's correct, but I come back to the advice we needed to provide on a day-to-day basis for the public was dependent on the day-to-day particulate matter and carbon monoxide in the air. I mean, I hope we will come to later, we'll come to the fact that my advice escalated as the fire went on. My advice about taking regular breaks from the smoke, taking respite from the smoke, escalated as time went on. But I don't accept the fact that because the advice in the first week was it would burn for a month, that our advice would have been any different to what it was during that first week.
We will, of course, work through the advice that you provided during the course of the fire. It's clear from paragraphs 43 and 44 of your statement that you were concerned at an early stage to obtain some data from the EPA about what the air quality in fact was. And Dr Torre and Mr Merritt have explained what they did after your request on the 11th of February. Did you understand towards the end of that first week that it was going to take some time before the highest possible quality data was available for you about fine particulate matter and carbon monoxide?
Well, we were requesting of the EPA that
Yes.
information, and the information that we were given from the EPA was that it does take some time for instruments to be calibrated before they could give us definitive information as opposed to indicative
Yes,
information.
but you did understand that in the interim they were able to provide some indicative information about air quality.
That's right.
To begin with, based on visibility reduction,
That's right.
but also based on handheld and temporary monitors
That's right.
that were in place. And you understood by the end of the first week, by Friday the 14th, that measurements of fine particulate matter and carbon monoxide in the south of Morwell were significantly higher than those being recorded at the Hourigan Road site in the northeast of the town.
We first received advice on the carbon monoxide level away from, so I'll leave carbon monoxide level in the mine, which is obviously an occupational health and safety issue for people in the mine. I was first advised of an elevated level away from the mine or on the mine edge on Saturday the 15th when I was rung by staff from the Incident Control Centre about the elevated instantaneous reading that eventually quite quickly led the incident controller to issue the warning. So that was the first information that I had about carbon monoxide in the community from the EPA. From the next day, the 16th of February, we began to receive, spot readings from the EPA on the level of carbon monoxide. The development of our carbon monoxide response protocol meant we needed more systematic rolling average with precise locations of where the readings were being taken. We needed that sort of the readings in that sort of systematic format to be able to take informed, considered decisions about what we needed to do about carbon monoxide.
It was Mr Merritt's evidence that in an emergency situation, particularly in the early stages of an emergency, sometimes you have to make do with indicative data.
Yes, that's
If
right.
that's the only information that is available, it's what should guide a decision or advice that's provided.
That's
Do you agree
right.
with that?
Yes.
And over that weekend of the 15th and 16th, you only had indicative data available about air quality on the southern side of Morwell.
That's
Do you
right.
agree with that?
Yes.
And so that was the only thing on which you could base a decision or advice.
That's right.
Before I get to the events of that weekend, I'd like to go to a community information sheet that was prepared by the Department of Health. It's the Detachment 7 of your statement. You refer to it in paragraph 53. As I understand what you say in paragraph 53, this community information sheet was prepared and distributed at the community meeting in Morwell on the 14th of February.
It was. That was my understanding, the first community meeting that was held. Senior staff from my office attended that meeting, handed out this written information to the community, and the feedback that they provided to me from that meeting, they also spoke at that meeting, answered community questions, and the feedback that I had from that meeting that the information was well received.
And we see from a handwritten annotation in the top right-hand corner that you approved this before it was distributed.
That's right, yes.
Approved it on the 14th of February, I
Yes.
assume, before it was distributed.
Did.
Can we have a look at the advice that is provided in the information sheet? On the second page, there's a section starting at the bottom of the first column called Protecting Your Health. Are we looking at the right document? Yes, we are. So there's a range of practical options that are provided for people in that column about how they can reduce the health impact of smoke. And the last of those is during extended very smoky conditions, sensitive individuals should consider temporarily staying with a friend or relative living outside the smoke-affected area.
That's right.
And that's very practical advice. The best way not to breathe in the smoke is not to be where the smoke is. Now, that was advice that never appeared in any of the smoke advisories, did it?
Well, it appeared in all of this other information which we gave to the community. So it appeared in numerous fact sheets which were given out through numerous channels on our website, obviously, given out through the community engagement activities. So the fact that the didn't appear in the EPA standard releases didn't mean that it wasn't available through many other channels.
Yes,
and
the EPA
through my media interviews as well.
Smoke alerts
Yes.
Quote you,
Yes.
and they are issued day by day, were they not? And they certainly don't include a suggestion that people might consider temporarily removing themselves from the smoky area.
No, they don't.
Towards the top left of that page, at the conclusion of a section that explains the risks of carbon monoxide both to firefighters and to community members, there's a statement that handheld monitors have surveyed for carbon monoxide levels in the Morwell township and around the perimeter of the mine. To date, levels of carbon monoxide are not a health concern from people, I think that should be who, are away from the actual coal fires, i.e. outside the boundary of the mine. What data did you have available as at the 14th of February about carbon monoxide levels outside the boundary of the mine?
Well, what we know about carbon monoxide is it is much more likely to be
That's not the question I asked you.
Right.
The question was what data did you have on the 14th of February about carbon monoxide levels outside the boundary of the mine?
We didn't have specific data, but I will bring you back to the fact that we know that carbon monoxide is much more a hazard for people in an enclosed area or very close to the mine. It is much less likely to be a hazard for those in the community.
But the fact was that as at the 14th of February, you really had no data about carbon monoxide levels outside the perimeter of the mine.
No, we didn't have specific data on that.
And yet you're prepared to provide this assurance to people that levels of carbon monoxide were not a health concern.
We did. Sorry, I'll need to check the record there because we have said handheld monitors have surveyed.
Yes.
So I'm sorry, I will need to go back and check what data we did have on that because we have said that handheld surveys were being done there. So I'll need to check that.
All right. Well, I'd be grateful if you would. Because it would be surprising, would it not, were you to provide that assurance without any data at all?
Yes.
Moving to what occurred on the 15th of February and the 16th of February in relation to carbon monoxide levels in the southern parts of Morwell, we've heard evidence from Commander Katsikas, who was a Deputy Incident Controller over that weekend, that on the 15th of February elevated carbon monoxide levels were detected around the perimeter of the mine and in the southern parts of Morwell. And that based on those readings, the incident controller decided to issue an emergency alert, a watch and act message that was sent out both via text message to people within an area on the southern side of Morwell and also was posted on the CFA website, and that message was downgraded later that evening after a wind change. When did you become aware that action had been taken?
I was rung around lunchtime on the 15th of February by one of the health staff in the regional incident control centre that the incident controller was considering issuing an alert based on a single instantaneous reading of elevated carbon monoxide.
Well, that wasn't Commander Katsikis' evidence. There were more than one reading. That was the base, but that was what you were told, wasn't it?
That's what I was told, yes. So I was informed that I then rang my Manager of Public Health Emergency Management and asked him to convene with my environmental health risk advisors and to provide a health risk assessment on that. Well, my understanding was on that single elevated carbon monoxide level. So I asked them to provide a risk assessment that would be given to me, that we could give to the incident controller as to the health implications of this incident. Prior to that being able to be completed, I was then rung back and advised that the Watch and Act alert had been issued.
All right, so was the risk assessment ever completed?
Yes, it was.
It was. Is that available to provide to the board?
I believe so. It should be in in the email documentation which has been provided.
All right. Well,
yes.
I've not seen it. It's not to say it hasn't been provided, but if it hasn't been, I'd be grateful if you could ensure that it is.
Okay. Yes.
Did you agree with the incident controller's decision to issue a Watch and Act alert on the 15th of February?
No, I don't think that was particularly helpful. The risk assessment was that with this instantaneous reading, which I was informed that the instantaneous reading was 14 parts per million, and that was quite close to the edge of the mine. We know that if you stand next to a modern vehicle exhaust or you stand next to your gas stove while you're cooking dinner, you can get levels of sort of 5 to 15 parts per million of carbon monoxide. We did not believe that this posed a risk such as that the Watch and Act alert was justified. On that afternoon, we commenced...
Right, just before you proceed, I want to put to you Commander Katsikis' evidence. His evidence, as I recall it from the transcript, was that there were a number of readings. His statement was that at around midday, Deputy Incident Controller O'Connell advised him that hazmat technicians were recording elevated CO readings within some parts of Morwell. His evidence, as I recall it, was that they were 13 parts per million on average, peaking at 20 parts per million near the police station. And there was then a meeting of various people involved in the incident management team. At the meeting, the scientific advisor, Warren Glover of the CFA, confirmed that CO levels in some parts of Morwell were high. And then there's reference to the weather conditions and the fact that there was no wind at that stage, but there was a wind change expected that afternoon. That suggests more extensive recordings of high carbon monoxide levels than had been conveyed to you, does it not?
Yes.
Certainly more than a single spot reading.
Well, that suggests that, if that's his evidence, yes.
Yes, all right. And your your department's risk assessment was conducted on the basis of a single spot reading of 13 parts per million.
Well, that was my advice at that time. I'll have to check with the team as to whether they were aware of other readings, but that was the advice that I had at the time, that it was a single high level.
All right. So you thought that the Watch and Act message was unhelpful?
I thought it was unhelpful. I thought it sent a very concerning message to the community where that wasn't necessary.
All right. What did you do about your view that it was an unhelpful warning?
In terms of specific...
What steps did you take next?
The steps that we took were to develop, and in conjunction obviously with the incident controller, a carbon monoxide protocol which would provide everybody with sound decision making as to what our advice to the incident controller would be with varying levels of carbon monoxide. And as I mentioned, single instantaneous high readings are really not a sound basis to make sound decision making. So on the 16th of February, my staff developed over that day the draft of the carbon monoxide protocol, which had the levels and the actions which would be taken according to levels of carbon monoxide, expected duration of the plume, and the location of those levels. So that protocol was in place from the 16th of February. That was subsequently peer reviewed and found to be an appropriate instrument to guide decision making.
Well, we'll come to the carbon monoxide protocol and the various peer reviews a little later. But that is based on a different standard from the ambient air quality standard set in the National Environment Protection Measures.
That's right, yes.
It's an acute exposure guide level 2.
That's right, yes.
And your staff, who among your staff worked up this draft protocol?
The staff that were principally involved was our principal health risk advisor, who's an air quality specialist.
Is that Vicky Lynch?
That's Vicky Lynch.
Mm-hmm.
One of my emergency management staff, which was Dr. Jane Canestra, who's an emergency physician, and Dr. Danny Satoris, who's the senior medical advisor, who's currently working with environmental health. And there are other staff as well providing support to that.
All right. Now, the smoky conditions persisted on the 16th of February. In fact, they got a great deal worse on the 16th of February. And the incident management team, Commander Katsikis' evidence remained concerned about high carbon monoxide levels in the area of Morwell near the mine. And Commander Katsikis' evidence was that there were readings of 20 to 30 parts per million, peaking at 60 parts per million. Was there any agreement reached during that afternoon of the 16th of February about who would be responsible for issuing community warnings about air quality from that point?
The incident controller is responsible for all aspects of the incident.
Yes.
I would expect incident controllers of any incident, whatever it be, that they seek appropriate health advice before issuing any advice to the community. As we've discussed earlier on, my role is providing health advice to the community, and my role is to provide health advice to the incident controller. So it is the incident controller's responsibility for overall control of the incident.
All right. Commander Katsikis' evidence was to the effect that there was an agreement reached in the course of that afternoon that responsibility for issuing community warnings would be removed from the incident controller and taken over by the Regional Control Centre. Were you involved in that?
No, I wasn't. And the incident controller cannot divest himself or herself of responsibility for communications. As I said, we of course provide the best possible advice and support, but the incident controller cannot divest himself or herself of responsibility for the incident.
Commander Katsikis also gave evidence that on the afternoon of the 16th of February, the Sunday, given the high carbon monoxide readings that were being recorded in the high 20s to the low 30s with a peak reading of 60 parts per million, there was discussion about evacuating the southern part of Morwell and that ultimately the incident controller had determined to draft a community message rather than move to a full-scale evacuation. And the evidence was that the incident controller, Mr Brown, and Commander Katsikis were advised by the regional controller, Andrew Zammit, that an agreement had been reached in relation to community warnings. We were then directed that information regarding elevated carbon monoxide levels be passed on from the hazmat sector via the scientific advisor to the EPA for data analysis. The EPA would then provide this information to the Department of Health, who would ultimately decide on the appropriate community warning to be issued. is that what you understand the agreement was on the afternoon of the 16th of February?
I wasn't advised of that on the afternoon of the 16th, but I think I made the comment about incident control. If I bring you back to the carbon monoxide protocol, which was agreed on the 16th of February and subsequently peer-reviewed as being appropriate, none of the carbon monoxide readings led to decisions, a recommendation from us of evacuation. Now, if you look at the carbon monoxide protocol, it does include, if the level is high enough and expected to persist for long enough, then a recommendation for evacuation would be made. And I would have made that recommendation to the incident controller had the levels of carbon monoxide fitted into the protocol where the table says we would recommend evacuation.
Yes,
we had the discussion yesterday about, Professor Brooke and you had the discussion about evacuation and the fact that we in the department don't, or me as the Chief Health Officer, under the Public Health and Wellbeing Act, I do not have the legal ability to require evacuation.
No, but the incident controller always has the ability to recommend evacuation.
The incident controller can recommend evacuation, and that's a matter for the incident controller and the emergency services. So what the point I'm trying to make is that having agreed on a carbon monoxide protocol, if the levels of carbon monoxide that we had received fitted into the categories which say evacuate, well, we would not have hesitated to give that advice to the incident controller.
You say that the carbon monoxide protocol had been agreed. Agreed between whom?
Agreed between our technical team, and that had also... my understanding was that there was discussion at the regional level with the incident controller, but obviously the technical advice came from my team.
All right, and as we will discover when we deal subsequently with the content of the protocol, the minimum level that is set as a trigger is 27 parts per million.
That's right.
Which is 3 times the standard in the level in the ambient air quality standard.
That's right. As we discussed about the ambient air quality standards, they are over a longer term. They're set for a longer term period. So the appropriate standards to use in the acute exposure setting such as this are what you described, the ambient air quality guideline levels.
Well, the ambient air quality standard allows for one exceedance of 9 parts per million over an 8-hour period per year, does it not?
But this was an extraordinary, unprecedented event.
Well, as I say, we'll deal separately with the content of the protocol, but it's your evidence that that protocol was agreed between your technical team with some input from the regional control centre.
Well, they were located at the regional control centre.
Right.
Some of them were and some of them were.
All right, and it was in place by the evening of the 16th of February, was it?
That's correct.
We provided yesterday with an email chain between Dr. Torre and Vicky Lynch, who is the medical advisor or the advisor health risk management you referred to.
That's right.
Is it possible that she's been referred to as a toxicologist?
Yes, she may have been referred to as a toxicologist. She's an air quality scientist.
All right. Now, this is an email chain, and I'll just ask you to ignore the first couple on the front page because that's one person forwarding it to another, forwarding it to my instructor. And if we start at the earliest, which is on the back, the second last page. Yes. There's a request from Ms Lynch to Dr Torre for tonight's air quality issues. there's a need for some data so that there can be a decision about whether the protocol is activated.
That's right.
And Dr. Torre then provides to Ms. Lynch the data that he has available, commencing 2 pages earlier. I think you're there, yes. The following results. So there's an 8-hour figure provided for the morning at the Morwell South residential area. There were concentrations that morning, averaged, ranged from 25 to 45 parts per million.
My understanding is that these are short-term, 5-minute monitorings.
Well, I just want you to read what's there. The first set of data that is given is an 8-hour average of 25 to 45 parts per million, is it not?
So I don't see where it said 8 hours.
Continuous CO air monitoring was undertaken at 5 locations in the Morwell South residential area, covering approximately 4 kilometres on the 16th of February. And we'll allow for some typographical errors, and then there's an 8-hour period between 12:30 in the morning and 8:30 in the morning. Concentrations averaged ranged from 25 to 45 parts per million. Now that's at a level that's sufficient to trigger the protocol, is it not?
Well, the advice that I had was that these data were...
Just attend to my question, Dr. Lester. That's at a level that is sufficient to trigger the protocol that was in place by that evening.
It was sufficient to consider the protocol, but the data that we had from here is that my understanding and my advice was that these were individual spot readings, and what we required to trigger the protocol was more than individual spot readings. They were actually rolling 1-hour averages, was what was agreed would be needed to trigger the protocol.
Right. Well, you're given for the morning an 8-hour average, are you not? And then for the afternoon, over a 5-hour period, there is a range of short-term results that are given from a range of locations in the southern area of Morwell, ranging from 7 at the lowest at the police station up to 57 at the highest at the Morwell Bowling Club. Now, these were 5-minute readings, but it is apparent from that table, is it not, that there were a series of readings taken.
Yes, there are a series of readings taken.
From which an average might have been inferred.
Again, we come back to the data we need for the protocol this data was not in the form that we needed for the protocol.
No, but this is the best. This is the best data that you had available on the evening of the 16th.
That's right.
And it is clear that there were more than one reading taken at a number of these locations from that table, is it not?
Yes.
And it would have been possible to obtain an average from those readings at those locations.
An average from the individual spot measurements.
Yes. So if we have a range of readings at the Morwell Bowling Club between 25 and 57, you might want to know when the first reading was taken, when the last reading was taken, what the readings in between were, and what they averaged out at.
Again, these were readings that were individual spot readings and were not considered, according to my advice, as suitable for activating the protocol.
But it was the best information available at the time.
Yes, it
and
was.
You must agree that the readings are at a concerningly high level.
Yes.
So there was information available on which to form a view, was there not?
There was information available, but not sufficient information in the form we needed to activate the protocol. And the protocol, as I've mentioned to you, was subsequently peer reviewed as the appropriate tool for decision making.
Dr. Torre then goes on to deal with the PM 2.5 levels. He advises that the levels recorded at the Morwell East site, which by this time had come online, were measured at 76 micrograms per cubic metre at 10 in the morning and at 85 at 2 in the afternoon, and then says that he estimates that levels at the Morwell Bowling Club were 2 to 3 times higher than that, which would put the higher reading, the afternoon reading, above 250 micrograms per cubic metre.
That's right.
Yes. So more than 10 times the advisory standard.
That's right.
Yes. So, was this data shared with you before Ms Lynch and her team made a decision about what action to take?
I don't recall whether I was specifically advised about the PM2.5 levels, but these PM2.5 levels, as you'll see when we discuss the PM2.5 protocol, would not trigger any different advice from the advice we were giving.
Right, so you don't remember whether this data was shared with you before Ms Lynch made a decision about what action to take?
I certainly remember the being advised of the carbon monoxide levels, and I remember reading Ms Lynch's assessment of those.
Yep.
I don't honestly recall whether I received the PM2.5 data that evening or not.
There's an email from Ms Lynch at 11 o'clock that night. Clearly people were putting in some long hours. Refers to a conversation that she'd had at 9:30. Did you participate in that conversation?
I don't believe I participated in a telephone conversation. I was obviously checking emails all the way through that day and evening.
No. And her judgment is set out below that the 5-minute average values are all below the acute exposure guideline level 2 for the shortest exposure time for 10 minutes.
Sorry, are we talking about carbon monoxide?
Yes, carbon monoxide. Regarding CO measurements, that section under there.
I'm just not sure where you're...
Sorry.
Here we are, yes.
You found it? It's a message to Paul Torre, copy to Chris Webb from Ms Lynch. So she finds that the levels that are recorded, because they were 5-minute average values, were not high enough to trigger the protocol that had been put in place that afternoon.
That's right.
She makes no attempt, does she, to obtain the best possible average over the afternoon that could be obtained from the different readings?
No, her judgment was that these spot readings were not sufficiently reliable information for us to trigger the protocol.
But she doesn't attempt to use the available data to gain an average over the afternoon.
No, as I just come back to the fact that the CO protocol relies on 1 hour rolling averages, not individual spot readings.
Then she deals with the PM 2.5 levels, and ultimately the only action that is recommended is a high-level smoke advisory.
That's right. Again, that those PM 2.5 levels would fit the protocol for issuing the high-level smoke advisory.
Well, yes, clearly.
Yes.
But there was no consideration of other action.
Not at that stage.
Given
no.
the indicative data that was available and what was known about the likely duration of the mine fire.
Vicky has put a note on the end there. DH will discuss possible media with radio requirements with the Chief Health Officer tomorrow.
Right. If I could tender that email. Thank you, Your Honour. You were copied into this email. You may not have read it until the next morning.
No, I certainly read the carbon monoxide Well, I must have read the lot because as I realised it's in one email. What I was obviously particularly concerned about was the carbon monoxide advice, but I certainly read this on that evening.
All right. And did you consider the advice to be appropriate?
Yes, I did. I rely on Ms Lynch is an extremely highly qualified person and I rely very heavily on her advice.
If we can just look at the advice that was issued the following day, there is a high-level smoke warning issued on the... that's the wrong date. Yes, issued on the 17th of February. There's a Chief Health Officer alert. It's behind tab 18.4 in the first folder.
I think 18 is in my second folder.
Okay.
So 18.4?
18.4, and it is document DOH 0001 001 0009 for the 17th of February. So that's the Monday following. And just to confirm, that was the warning that you issued in light of the very high levels of carbon monoxide that had been recorded the previous afternoon and the very high levels of smoke.
That's right.
In Morwell.
Yes.
Was there anything more than this that was issued on the 17th of February?
I'd have to check my my media log, which is somewhere there in attachment 18. There was much media activity happening around this time, so I'd have to check that to see exactly what was done on that day.
Right,
but
but
as I said, there were many means of communications being undertaken sort of from the 11th of February.
There's certainly no advice in this Chief Health Officer alert that people in vulnerable groups should consider leaving the area.
No.
One of those vulnerable groups is children, and we had some evidence earlier this week from Mr Pole of the Department of Education about steps that department took to address concerns that had been raised by local principals about air quality in schools and difficulties in keeping children confined indefinitely. The Department of Education sought your advice about that, did they not?
That's right, they did.
And if we could have on the screen and made available to Dr Lester attachment 45 to Mr Pole's statement. Mr Pole's evidence, Dr Lester, was that on the 18th of February, following the SEMT meeting, State Emergency Management Team meeting, there'd been a discussion between you and the department's manager, Emergency Management, at which she reported to you that a report had been received from a children's service of children exhibiting hyperactivity, headaches, flushed faces and longer sleep times. Do you recall that conversation?
Yes, I do.
And Mr Pole's evidence, and this was based on what he was told by his manager, Emergency Management, was that you indicated that these symptoms may be consistent with carbon monoxide exposure.
With general smoke exposure,
With
yes.
smoke exposure. And your advice orally at that time was that services the Children's Services south of Commercial Road relocate, which would be consistent with your current recommendation, current at that time, that people spend some time out of the smoke.
That's right. In all of the media statements and the fact sheets which you saw were given out at the community meeting, which were then available through our website and through the community engagement activities, the advice that people minimise their time in the smoke and take regular breaks out of the smoke was given through all those mediums. In the discussion I had with the Department of Education officials, we agreed that children being in a vulnerable group, we agreed that a good way to enable children to have regular breaks out of the smoke and while they were being educated was to relocate them out to other schools. And the Department of Education officials indicated that this was able to be done. So we agreed that that was consistent with our advice to other vulnerable groups in the community, that they minimise their exposure to the smoke.
All right. Now, why the concern about consistency?
Well, I think we've heard from the community that what they require is consistent messages.
In your mind, at the time when you were
Yes.
providing the advice, why were you concerned that your advice to the Department of Education about what should be done with children's services in very smoky areas of Morwell be consistent with your broad public health advice?
Well, I don't think I would want to be giving two sets of inconsistent messages
No.
to the public. I don't think that would be helpful.
All right. So after this discussion, you then wrote to Mr. Pole and Ms. McKegney, who I think was the Manager of Emergency Management, and confirmed your advice in writing. And that advice is that on the basis that some children from one of your early learning facilities have reported symptoms which would be consistent with smoke exposure, and the fact that our recommendation has been for the past couple of days for vulnerable people to spend time out of the smoke if possible, we would advise that your facilities south of Commercial Road, i.e. nearest to the, I expect that's supposed to be mine, are closed and or have provision for temporary relocation of the children out of the smoke.
That's right.
So the initial step is to close the facility located south of Commercial Road and or to relocate the facility if that's possible.
That's right.
So the Department of Education were looking to you, were they not, for advice about whether relocating their schools was an appropriate step?
Yes, they were.
And you appreciated that they would not move without your advice, that it was an appropriate step?
Well, certainly they came to seek my advice on that, yes.
Having provided that advice to the Department of Education on the 18th of February, did you revisit the content of the advice that you were providing to the community generally?
Well, the advice we were providing to the community generally, as you've read on that first fact sheet, included all of those things which were, as I said, were consistent with the advice we were giving about taking regular breaks from the smoke.
Although that didn't appear on the alert that you'd published on the 17th of February, did it?
It did
That
appear
range
on
of
all of
options.
the other. It did appear on all of the other material that we were using, our community fact sheets, etc.
Right, but in the alert with the red border that
Yes.
you published on the 17th of February, there was no mention of the desirability of people in vulnerable groups moving out of the area while the smoke persisted.
I should mention that the alert, my Chief Health Officer alerts, are more directed at health professionals than the community. Our community fact sheets are obviously the ones that are directed primarily at the community.
The alerts are posted on the Department of Health website, are
They
they
are,
not?
yes.
And someone browsing the internet looking for advice may well just look at your alert. Do you accept that?
They may, yes.
And it would be reasonable for that person to expect that advice that you wanted them to receive would be contained in the alert.
Yes, that would be reasonable.
Yes, they shouldn't have to go hunting for a community information fact sheet for the details, should they, Dr. Lester?
Well, most people will look at the community information rather than the health professionals' information.
Forgive me, but on your website, the alerts are available for anyone to look at, are they not?
Yes, they are. Yes.
It's not in a health professionals only section of the Department of Health website.
No, it's not.
No.
It's going to move on while we've got that on screen. I query whether there's anything that there was further discussion with or further discussion with as to schools north of Commercial Road, unless you're going into that area anyway.
I'll deal with the question of north and south.
Okay, later.
Subsequently.
Ms Richards, may I also seek clarification? On the alert and on the community fact sheet, there's a 1300 telephone number.
Mm-hmm.
So if I was living in Morwell and I rang that number, what would it tell me? On the 18th of February.
Can you point me to the to where that is?
Perhaps if we go to there's a subsequent community or an advisory issued on the 21st of February.
Oh, I see the 1300 number on the alert is our environmental health unit at the Department of Health.
But also on the 14th, the community information sheet that you've signed, which is attachment 7, it encourages the community for more information. That's right, page 3. So for more information, just go up a bit. For more information on the health effects of the smoke, contact that number 1300 761874 during business hours.
Mm-hmm.
So if I was a mother with children and I was looking at this community alert on the 14th of February and I rang that number, what would I be advised?
You would be talking to staff in our environmental health unit, so you would be advised exactly what those messages were that were on the community fact sheet.
Would I be speaking to a person?
Yes, of course you would.
Okay, and I'd be directed to go to this fact sheet, would I?
That's right. And in fact, we did receive many phone calls and emails.
And what was apart from going back to this fact sheet, what would I be told?
Well, you would be told the messages that are contained in the fact sheet.
So it's not really more information, it's just repeating this community information sheet.
Well, people may have other individual questions that our staff, if they felt qualified to answer them, if that's within their expertise, they would answer them. If that was related to a clinical health matter, then they would refer the person on to their own doctor.
Thank you.
There was a further advisory issued by you on the 21st of February. If we could have a look at that. It's behind tab 18.3 and it's document number DOH.0001.001.008 under advisories. So this is, as I understand it, the next advisory issued after the one we were looking at, dated the 17th of February,
That's
which
right.
was an alert. And there's an identification of the at-risk groups. And then under the heading prevention on the second page, those with heart or lung conditions and people with asthma are advised to take their medication, follow their asthma plan. Everyone, but particularly those at high risk, is advised to avoid prolonged or heavy physical activity outdoors and keep informed of fire activity. And those with symptoms such as wheezing, chest tightness and difficulty breathing should seek medical advice. And again, there's no suggestion here that people seek a break out of the smoke, find an air-conditioned place to spend time, or if they can, move out of the area until the smoke clears.
That's right. Again, these are more directed at health professionals, so those other messages were included in the information which was more directed at the community.
The message under prevention is not directed to a health professional, is it, Dr. Lester? It's advice that people should take their medication and, if they're experiencing symptoms, see their doctor.
That's the advice that we would expect health professionals to be giving their patients.
Well, by the time they're consulting with their patients, the patient's already seeing the doctor.
Well, they're not necessarily seeing the doctor for those conditions. They might be coming in for their monthly checkup or their pap smear or whatever.
But again, this is an advisory that is published on the Department of Health website that is available for anyone who wants to know what the Chief Health Officer's advice is to consult. And it doesn't contain any practical options about minimising exposure to smoke, does it? Apart from avoiding prolonged or heavy physical activity outdoors. Now, can we have a look at the data that you did collect from the EPA, which you've provided to us in a graph? The PM 2.5 data is referred to at paragraph 67, and it should be behind tab 14, but it may be behind tab 15 in your folder. So this records PM 2.5 readings as a rolling 24-hour average from the time that data started to be provided from the East Morwell site, and that's the blue line.
That's right.
And the mobile laboratory at the bowling club down the end of the road here.
That's right.
And that's the red line. And of course there is an entire week of smoke that's not recorded on this graph.
That's right.
Yes. And there is a rough correlation between the levels recorded at the Hourigan Road site and the levels recorded at the bowling club. They tend to peak at about the same time.
That's right.
Although the levels recorded south of Morwell are significantly higher.
That's right.
Yes. All right. So that was the data that you had available. I take it you didn't have it in this graph form as you went along. You had day-by-day readings.
We're having day-by-day readings, that's right.
Together with weather forecast information?
Yes, the EPA would provide their summary of the forecast information.
Yes, and generally speaking, a southwesterly wind was likely to result in a peak. Did you understand that as you went along?
Yes.
All right, and the other summary of the data that you've provided us with, before I leave that, I should note there were periods on the 21st and 22nd of February when the PM 2.5 reading at the bowling club significantly exceeded the 250 micrograms per cubic metre trigger level. And there was a smaller spike period on the 27th and 28th of February.
When you say trigger level, are you referring to the PM 2.5 protocol?
Yes.
The primary objective of the PM 2.5 protocol, you will see, is to prevent vulnerable groups from spending more than 3 days in a level of more than 250. And that protocol, again, was peer-reviewed as being appropriate.
Can we deal with that in a while? I'd
Sure.
just like to work through the events first, and then I'll come back to the protocol, because the protocol wasn't in place until March, I think.
Well, it wasn't signed. It wasn't officially signed until then. But again, it was in practical use much earlier than that.
And certainly, the levels in the south of Morwell exceed right up until the 3rd of March the advisory standard for PM 2.5.
That's right.
Now, the other summary document that gives a picture of carbon monoxide levels is attachment 10 to your statement. And here we have the blue line is the Morwell East reading. The green line is the Morwell South reading from the mobile laboratory at the bowling club. That commences on, I think, the 22nd of February. And again, we have a gap of more than a week at the beginning, and critically we don't have that very bad weekend of the 15th and 16th recorded.
That's right.
But we do see that there were only 3 periods when carbon monoxide levels at Morwell South exceeded the 9 parts per million threshold.
That's right.
Rather than the 27 parts per million threshold that the protocol adopts.
That's right.
And again, they coincide with the peak periods roughly, 21st, 22nd, and the 27th, 28th of February. Now, on the 27th of February, I withdraw that. On the 28th of February, you changed the advice that you're providing to the community. And if we look at tab 18.23, that contains a media release from you dated the 28th of February.
Oh, sorry, 18.23, is it?
Yes, assuming our folders are the same.
Yes.
A news release, Friday the 28th of February. And that was accompanied by an information update, I believe it was, that was issued on the same day. And your advice changed. Sorry, it's a community update that was issued on the same day, the 28th of February. So your advice changed from advising people in at-risk groups to reduce their exposure to smoke and ash to consider temporary relocation. Why did you change your advice on the 28th of February?
Over the period preceding that, the advice that I was giving through the community fact sheets and through the daily media activity that I was doing was to the community to reduce and, if possible, avoid their exposure.
But my question was, why did you change that advice
Yes,
on the 28th
if I could just
of
tell
February?
a story about that, if I could. Over that period of time, I just lost my train of thought, to reduce their exposure to the smoke. The government opened on the 19th of February a community respite centre in Morwell, which we encourage people to use if they didn't have any other means of getting out of the smoke. They could go to the community respite centre. There was a free bus there. We were continuing to push that message over that period of time. We were continuing to escalate the emphasis of that message to take regular breaks if they could. The government provided respite grants for people to move out of the area, to take short-term breaks out of the area if they could. In the meantime, we were looking at these PM2.5 levels and we were constructing the PM2.5 protocol. With the PM2.5 protocol, you will see that as I mentioned, the primary objective of the PM2.5 protocol was to avoid vulnerable groups being exposed to PM2.5 levels over 250 for more than 3 consecutive days. If I go back to you, could you just point me to which attachment the PM2.5 protocol is at? The PM2.5 level is at?
I really don't want to go to the protocol at this stage,
sorry,
Dr. Lester.
the levels,
I would like
right?
you to answer the question, which was why did you change your advice on the 28th of February?
The PM2.5 levels, which started to go up on the 26th of February. So you'll see that after
Yes.
coming down significantly, they did start to go up on the 26th of February. I mentioned before in my evidence that it's not just the level of exposure to something, but it's the period of time you spend in
Yes.
that exposure, which increases the risk of adverse events occurring. Now, at this stage, as you heard yesterday from Professor Brooke, we weren't seeing any serious health events through the hospital, through Ambulance Victoria, through Nurse on Call. So that was a comfort to us. However, on the 26th and 27th of February, I started to see the PM2.5 levels rise again. And on the 27th of February, I had a specific advice from Commissioner Lapsley that the fire would burn for at least another 2 weeks. So I was concerned by that if that level continued on the trajectory that it had on the 26th and 27th, that we would exceed the 3 days of 250 or more. So I decided on the 27th of February that I was not willing to let this go on further, so that might be exceeded on the weekend, and we really needed to issue that advice. So I discussed that advice on Thursday evening with the whole of government emergency committee, and that advice was issued on the Friday. Now, as you will see from the actual levels of PM2.5, in fact, they did actually drop on the 28th. So we would not have exceeded what was in the protocol. However, as I said, I was sufficiently concerned that vulnerable groups had been in the smoke for long enough, and they needed to be more strongly recommended to temporarily relocate, rather than the less strong message of make sure you take regular breaks out of the smoke.
Yes. Well, your advice is only to people in vulnerable groups to consider temporary relocation.
Yes.
It's not that they must evacuate.
No,
It's not even a strong recommendation that they should leave. It's just advice that they should consider temporary relocation.
That's right.
So the next question is, why did you not give that advice in the first week of the fire?
The hazard that we were seeing, we need to give advice which is proportionate to the risk of what we were seeing.
Yes, and
you take the question of evacuation presents its own risks.
Well,
if you dislocate people...
Nobody's asking about evacuation at this point.
Well, you did ask me about evacuation.
No, I asked you why you did not give the advice to people in vulnerable groups to consider temporary relocation in the first week of the fire.
The risk of adverse events happening increases as the longer people are exposed to the smoke.
Yes.
The risk of adverse events increases. The actual level of the smoke, as you've seen from the PM2.5 graph, varied quite considerably across that time. So we needed to give advice which was proportionate to the risk of what we were seeing.
Knowing that the fire was predicted to burn for up to a month.
Yes, that's
right. From the
right.
first week of the fire.
But we need to give advice which is proportionate to the risk, and we need to give advice which is based on the evidence that we have. The levels may have gone down quite significantly, even though the fire was burning. So the risk of an adverse event happening if you're exposed to particulate matter higher than 250 over 1 day is one thing. If it goes down, the body recovers. So if you're exposed to further levels, then the risk of an adverse event happening is obviously increased. Now, at this stage, we were carefully monitoring the information we were receiving from the hospital, nurse on call, general practitioners, and fortunately we were not seeing any serious health effects, which was obviously a great comfort to us. But as I said, our PM2.5 protocol, which was agreed and peer-reviewed that it was appropriate, was that strong advice for temporary relocation would be given if there was predicted to be more than 250 for a 3-day period.
Is the reason that you didn't provide this advice in the first week of the fire that you hadn't appreciated that the fire was going to burn for as long as it did?
Well, no. As you pointed out, that information was discussed at the State Emergency Management Team meeting. But again, when we look at the levels of PM2.5, they fluctuate quite dramatically across the time period.
Yes, although at every point in South Morwell, up to end of the first week of March, they're above the advisory standard for PM2.5, are they not?
They are above the advisory standard.
And in some cases 20 times.
They are above the advisory standard, but the advisory standard is set for a longer term period in mind. It's set for protection of health over a longer term period.
Yes,
perhaps
because
if
it's
I
an
could
advisory
take you,
standard, we don't have a goal of exceedances per year.
That's right, we don't.
Avoided.
If I may, could I
Although
take you to...
we do have that goal in relation to PM10 levels, do we not?
That's right, we do.
Which is five days over a year.
If I may, could I take you to attachment 13, which was, as well as having the PM2.5 protocol peer reviewed by an expert toxicology firm, I also consulted with my other state and territory colleagues, both the managers of environmental health in the other states and territories and the other chief health officers through the Australian Health Protection Principal Committee. I consulted with them with the environmental...
Between the 5th and 7th of March?
We consulted with the environmental health managers on the evening of the 27th and later with the chief health officers. And I would just take you to attachment 13, which is the advice we received from the New South Wales Health Department. The second dot point from the bottom, and remember this was advice that was given on the data that they were given on the 27th of February. The advice in the proposed protocol is quite strong. The individual risk from PM is small and unlikely to justify a government recommendation that vulnerable groups should relocate. Relocation is potentially costly and presents its own health risks.
This was advice that you received on the 7th of March?
This was advice that was given verbally on the 27th of February as well.
Right. Well, that is recorded in attachment 14, is it not?
I don't have an attachment 14.
Well, there should be it might be 13. There's minutes of a meeting of the Environmental Health Standing Committee, that one. Might be behind tab 13.
I don't have that in 13.
Could a copy of that be provided to Dr. Lester?
Thank you.
Right, so this was the input that you had from this standing committee on the 27th of February when you made your decision to change your advice.
That's right.
The written comments came later.
That's right.
At the end of the first week in March.
That's right.
And there is concern expressed at the second dot point that relocating sensitive groups could set an inappropriate precedent. What is the harm in advising people who are living in an intensely smoky area that they should consider temporarily relocating until the smoke clears?
The comment there was related to what our colleagues felt was the level of risk, and the comment that if we gave a very strong recommendation that people relocate, i.e. almost equivalent to an evacuation, you dislocate people from their surroundings.
Can I stop you there?
Dislocate people.
Suggesting to people that they consider temporarily relocating is not equivalent to an evacuation, is it?
No.
By no stretch of the imagination is it equivalent to an evacuation.
No.
There will not be police knocking on your door saying, "Get out now," will there?
No, not with that
which
advice,
is what an evacuation involves, does
That's
it not?
That's right, yes.
This is advice to the community about what they should do to cope with persistent levels of high smoke. And it's very gentle advice that they should consider temporarily relocating. Why was that advice not given in the first week of the fire?
To be honest, I think I've answered that question. I think I have answered that question, saying we needed to look at the level of risk on a day-by-day basis. We did, from the start, say to the community, minimise your time in the smoke, take regular breaks from the smoke if you can. And as time went on, we tried to emphasise the fact that we were recommending people to take time out of the smoke. So all along we were giving that message to the community. The advice we were given from the Environmental Health Standing Committee was that they felt that we were being quite conservative, and as I said, you'd have to speak to them as to that view, but it was their view that the level of risk, the level of absolute risk, was quite small.
In hindsight, do you think you should have provided that advice at an earlier stage in the fire, that people in vulnerable groups should consider temporary relocation?
I think that the advice we provided was proportionate to the level of risk, and the advice we provided escalated according to the length of time that the vulnerable groups were spending in the smoke, up until the 27th of February, when, as I said, when I decided to issue that stronger advice, even though, according to our protocol, it actually turned out to be reasonably conservative.
If I can ask you about the terms of the advice that you provided on the 28th of February, you've previously identified children as a vulnerable group, and your advice to the Department of Education would suggest that includes school-aged children. Why did you limit the advice to preschool-aged children under 5?
The advice to the Department of Education was based on a general discussion on children. Now, the advice that they gave to me on that day was that there was only one early childhood centre in the southern part of Morwell, and that had closed of its own volition. So the advice that I gave to the Department of Education was children generally. Now, we know...
But you appreciated, being the Department of Education, they were asking about school-aged children.
No, they're responsible for early childhood education as well.
But they also run state schools.
Yes, they do.
Primary schools,
yes.
And children are generally aged 5 and over at primary schools. You accept that?
That's right, yes.
And so the advice you're providing to the Department of Education about closure or relocation of their facility related to school-aged children, did it not?
They advised me, we discussed early childhood as well, and the advice they gave me on the day was that there was one childcare facility in the southern part of Morwell,
which had already
and that
closed.
had already closed.
Yes. And so they were seeking your advice about what they should do with their schools.
With the schools, yes.
Which contain school-aged children.
That's right.
So my question to you is, why was the advice in your 28th of February community update limited to children of preschool age, under 5?
Because, as we discussed before, the younger children are, the more vulnerable they are. So in terms of providing the advice to the most vulnerable groups, we included children under school age, again knowing that children of school age had already been taken out of the smoke.
Well, their schools had been relocated, but
Their
if they were
schools had been
living in the
relocated.
southern part of Morwell, their families still had to consider whether they should relocate, did they not?
That's right, but what we know is that the children who are most at risk are those of the young age.
Is there any other reason for choosing 5 as the dividing line?
Again, it's a relatively arbitrary line. Obviously, it's a gradation of risk as you go up, so the 65 and over, it's a reasonable line based on the evidence.
Now, the other arbitrary line in your advice was south of Commercial Road.
Mm-hmm.
Why did you choose that as the geographical boundary of your advice?
If you look at the data as we have for the particulate matter from the monitoring station located in Morwell South, down here at the bowling club, compared to the monitoring station that was located north of Commercial Road, you'll see a really, a large distinction in the levels that were experienced.
Yes, and we're also aware of where those stations are located.
Yes.
And the East Morwell monitoring station is located at a fair distance away from Commercial Road. It's located up where that hand is pointing.
Yes.
So, apart from that data, the data from the monitoring station at Hourigan Road, the data from the monitoring station at the bowling club, did you have any other information about the distribution of the smoke across Morwell?
We know the particulate matter falls out quite quickly as you go away from the fire, but those two stations were what was being reported to us from the EPA.
The EPA have given evidence that they were using a travel blanket driving around Morwell. Did they provide that data to you that gives a spatial representation of where the smoke was and was not?
I don't recall that. They may have provided it to some of my staff. I'd need to check that.
No. So, but as best you can recall, your selection of that dividing line Commercial Road was based on the different readings from the bowling club and the Hourigan Road site.
Yes, you can see, as I said, clearly from the data that Morwell South was much more severely affected, and you would expect that from the location of the mine. The actual dividing line, the actual decision about the dividing line was discussed on the morning of the 28th at a meeting where Latrobe City Council were present, and we discussed this very issue about what was an appropriate demarcation point, and they were in agreement that the Commercial Road was the appropriate demarcation point.
Was that an appropriate demarcation point for eligibility for assistance with relocation?
Well, I can't really comment on that. I mean, my advice is based on health advice. The government subsequently chose to give financial and logistical assistance based on my health advice. My health advice, as I said, I believe was soundly based on the evidence.
There's a diagram that you have provided us at attachment 20, which has definitely been the second folder. Which you refer to at paragraph 88. Yes, that's right. This is a diagrammatic representation of the smoke impact at Morwell. There's other evidence that the inquiry's heard that suggests that this diagram does not represent the distribution of smoke in Morwell. It doesn't represent the reality of what people were experiencing and breathing. Is there a scientific basis for this diagram, Dr. Lester?
Look, I believe it's a modelling prediction. So it's certainly not something that I relied on in terms of giving my health advice. I relied on the data that we were seeing.
So, and the only data was the data from those two monitoring sites?
That's right, yes.
All right, so we can put this aside as really providing any explanation of the movement of smoke in Morwell?
Yes, it's an indication, that's all.
In fact, the note on the bottom suggests that it was an attempt to explain why the dividing line had been selected.
It's not something that I generated, no.
No, who did?
Look, I'm honestly not sure. I think it may have been the CFA, but I'm not sure about that.
Now, your advice was lifted on not until the 17th of March, although the PM 2.5 levels that were being recorded at both stations significantly reduced from early March.
That's right.
And remained well below the 250 micrograms per cubic metre level that had been identified in the protocol as needing to be avoided. Why did you continue to maintain your advice that people temporarily relocate until the 17th of March, given what what readings were coming back?
As soon as we issued the temporary relocation advice, we drafted a protocol for what I would use to lift that advice.
All right. And is that the document that we see behind tab 21? Basis for recommendation by the Chief Health Officer to lift temporary relocation advice?
That's the title of the document. I'll just find it. Yes, that's that document.
All right. So your trigger level for lifting the advice is significantly lower than your trigger level for providing the advice to temporarily relocate in the first place.
Well, we felt that it wouldn't be helpful if we got people to move back, and then the fire flared again. So I was in constant contact with Commissioner Lapsley about his assessment of the status of the fire.
All right. And by this time, by the time you were satisfied of all of these matters,
Yes.
17th of March, it had been declared controlled for a week.
That's right, it had.
Right. Now, I've been promising you that we'd come to the carbon monoxide protocol for some time now, Dr. Lester. You have provided it, you referred to it at paragraph 55 of your statement, and it appears behind tab 8. Now, your evidence was that this was developed initially on the afternoon of the 16th of February.
Yes, on the day of the 16th of
Yes.
February.
And it, in its final form, is dated the 27th of February.
Yes.
But it was a guide for decision making for you and people who advise you from the 16th of February.
That's correct.
Is that correct?
Yes.
Can you explain how it operates? What are the trigger levels and what level triggers what action?
Well, the table there describes, firstly, if I go back to the minimum data set for decision making, being the rolling average 1 hour levels, the precise location of the measured levels, and the forecast for the next 24 hours. There's then a table as to what would happen when particular levels reach particular, when levels are at a particular level, and then what the predicted duration of the plume is.
Right. Is that at figure 2, that table?
That's right, that's at figure 2 of the protocol, page 3.
All right, and we see that the lowest level that would trigger a watch and act message is 27 parts per million.
That's right, where the plume was predicted to be more than 8 hours.
And that is taken from the acute exposure guide level 2.
That's right.
Which is developed by the United States Environment Protection Authority.
That's right.
Now, you've mentioned several times that you had this document peer reviewed. It was peer reviewed by some consultant, toxicology consultants, Toxicos.
That's correct.
And the person who conducted the review within Toxicos was Lynn Dennison, I gather, from
that's correct.
From the information provided inside that document. Ms Dennison is a former employee of the EPA, is she not?
That's correct.
And an environmental scientist.
Yes.
Not medically qualified?
I don't believe so.
No. The EPA has also had, because it was a joint protocol, was it not, this? The
Yes.
EPA also had the protocol peer reviewed by 2 epidemiologists, Dr. Faye Johnston and Professor Ross Anderson. And both of those people express concern about the appropriateness of the levels that are chosen. And in particular, whether over a prolonged event such as this one, it's appropriate to use the acute exposure standard. And both of them suggest that much lower trigger levels should be included in the protocol. Did the EPA share those peer-reviewed documents with you?
Not with me.
No.
I'd have to check whether they shared those with my staff, but I was not aware at the time that they'd had the protocol peer-reviewed separately.
No. And it's a little strange, to me at least, that the EPA should engage epidemiologists while the Chief Health Officer should engage an environmental scientist to conduct a peer review of this document.
Well, Lynn Dennison is a very well qualified person, and that consulting firm is a very highly regarded consulting firm.
Yes, but equally, Dr. Johnston and Professor Anderson are well-respected epidemiologists.
Yes, they are.
With views whose views should be considered. And now that the fire's no longer burning and there's an opportunity to refine the protocol, would you accept that it should be reviewed in light of their opinion?
We can certainly review that and take their opinion into account, yes.
Similarly with the PM 2.5 protocol, now this you've provided, referred to at paragraph 63 behind tab 11 as attachment 11. Now it's dated the 13th of March, and your evidence in your statement is that development of it started on the 25th of February.
Yes, that's right.
And you had that consultation with your colleagues in other jurisdictions on the 27th of February.
That's right.
So it was guiding your decision-making on the 27th and 28th of February.
It was, yes.
The peer review was conducted again by Ms Dennison at Toxicos, and she provided her feedback on the 5th of March.
That's right.
And then you finalised it on the 13th of March.
The signature on it was on the 13th of March, so it was in use prior to that. It was just a matter of the signature being on it on the 13th of March.
Now, the EPA has not provided us with any peer review of this document, but it is a joint protocol again.
Yes.
Intended to be. It would be of benefit, would it not, for this document to be reviewed by the same epidemiologists who reviewed the carbon monoxide protocol?
Yes, that may be a benefit.
And so you would not object to the recommendation that was made by Dr. Torre and Ms Richardson that there be, now that we all have time, a fuller review of both of these protocols by an expert panel?
I would welcome that.
One other piece of peer input that you obtained reasonably late in the piece, but it's a very useful document, is the rapid health risk assessment from Monash. A number of people at Monash in the School of Medicine, Nursing and Health Sciences. Why did you seek this rapid health risk assessment? Sorry, and so you can find it. It's behind tab 16 of your folder.
No, it's not behind tab 16 in my folder.
15? 15. Someone has cunningly shuffled my documents. It's possibly me.
Again, we sought this as another consultation from experts that would help us. Unfortunately, this didn't arrive as quickly as we might have hoped, but we were seeking to get additional expert opinion into our decision making.
All right, so by the time it arrived, really, all the critical decisions had been made.
That's correct, yes.
But it is a very thorough review of the available evidence. and in particular there is a section starting on page 18 that deals with what is the risk and how does risk change with persisting exposure. And in a reasonably confronting table, there's some modelling of increased mortality rates that might be expected over successive durations of exposure. And we see from that, as we discussed earlier on this morning, that the risk increases with the duration of exposure.
That's right.
So while at 3 weeks it's not significant, by the time you get to 3 months, it does start to become significant.
That's right. They assess this at exposures of PM 2.5 for 250 for the southern part of Morwell. And I think at the standard for the northern part of Morwell.
Yes. Now, this assessment was based, as I understand it, on the average Victorian population.
The expected deaths would be based on the average Victorian population.
Yes, it would have been helpful to have it adjusted for the known demographic of Morwell or the Latrobe Valley, would it not?
Well, the expected death rate, it would be helpful to have it specific for Morwell, but I presume that they use the expected death rate for the whole of Victoria as a more stable measure to compare against.
Now, the last thing I'd like to ask you about, Dr. Lester, is the long-term health study.
Could I perhaps just bring you back to the conclusion
Certainly.
of the rapid health risk assessment? Was that for exposures of 250 continually in the southern part of Morwell, then no additional deaths would be expected if that continued for 6 weeks. So it would be at 3 months that they would expect to see some increase in deaths.
Yes.
Obviously, that's at the very severe end, obviously,
yes.
of health
and we're
effects.
dealing with death, and of course there can be
That's
a range
right.
of health effects
And there are
short
a range
of
of
death
health
that it is
effects there.
desirable to avoid.
Absolutely, but that's the conclusion that this assessment, which focused on mortality, came to.
Right. Now, the long-term health study, when did you identify a need to undertake a long-term health study?
I think as the exposure started to progress from beyond just the your normal bushfire exposure of a few days or a week, we were trawling the evidence for what we might expect from exposures. Obviously, my internal experts did a lot of literature reviewing. Dr. Lynn Dennison from Toxicos provided a literature review for us. We also, obviously, the Monash group provided that literature review for us as well as part of the risk assessment. It was when we were getting beyond that standard short-term exposure that we realised that there really was a bit of a gap in the evidence as to what if any, long-term health effects might be expected from this event. So we started talking at that time about the fact that we needed to provide assurance to the community and we needed to listen to community concerns as well as try and fill that gap in the evidence.
All right, and you've identified a number of issues for the study at paragraph 92. At paragraph 94. At
Can
paragraph,
you just point me to the attachment number?
I wasn't going to an attachment at this
Oh,
stage.
okay, that's all right.
Paragraph 95, you say that the proposed duration of the study is 10 years. That seems like a very short duration for a long-term health study. Why only 10 years?
I think it would be ideal if the study, I think it would be very ideal if the study continued longer than that. It really is not feasible for the government to be entering into contracts at this stage for any longer than 10 years. I would certainly be wanting to see the study continue for longer than that.
All right, so the 10-year constraint is imposed by government tendering rules, is that correct?
Well, it's not a particular rule, but in terms of engaging in government contracts for a very long period of time, for what's likely to be a substantial sum, then I think, and the advice that I've received is that a 10-year contract is the appropriate upper limit at the moment. As I said, my expectation and hope would be that it would continue for much longer than that.
Of course, if the study were conducted by the Department of Health without being contracted out, there wouldn't be that limitation, would there?
I don't think it would be appropriate for the department to be I don't think it would be appropriate for the study to be conducted by the Department of Health. We don't have the expertise that an external expert research group would have. We really do need to get someone who's got that external research expertise to do this.
The difficulty I'm having is in understanding why, if you want to conduct a long-term health study, you can't establish a long-term health study. 10 years is not, I mean, in the scheme of things, it's not long enough, is it?
Well, I think I've answered that question.
The constraint is, I just want to be clear about the constraint, because if it's government tendering rules, those might be able to be addressed.
Well, again, I think I've answered that. I think it's, given the substantial nature of this, that it is only reasonable to be contracting initially for a period of 10 years, and then after that, depending on performance, etc., the decisions of the people at the time, I think it would be more than appropriate, or I think it would be very desirable for it to continue for a longer period.
But that decision won't be made until the end of the initial 10-year period, is
That's right, yes.
The governance arrangements that are proposed is that the successful tenderer would form the advisory committee, which would include you.
Myself, that's right.
Could the Department of Health not form the advisory committee or steering committee to oversee what the successful tenderer does?
Yes, the Department of Health could convene that.
And that may address the duration constraint that you have because of the tendering requirements.
Well, no, it doesn't change the fact that to enter into an extremely long duration contract would be very unusual.
There are two
the
separate...
governance of the advisory committee is quite a separate issue.
There are two separate issues, are there not? There's a decision to undertake a long-term health study for an appropriate duration, and there is the way in which that study is carried out.
Yes.
Now, to allow the contracting rules to determine the duration of the study is, I suggest, the tail wagging the dog.
It hasn't. There's been nothing in there which says the study will go for 10 years and stop. The intention would be that the study would continue.
Well, your statement of paragraph 95 says the proposed duration of the study is 10 years.
That is because that's written for the tenderer, so they know what contract they will be entering into.
Yes, but if the Department of Health decides that it wants to conduct a study for 20 or 30 years, it can make that decision and then let contracts as required to implement that decision, can it not?
So perhaps we should change the wording to, we would like to see a long-term health study of 20 years or more, but the initial contract will be set for a period of 10 years. So perhaps that might be helpful?
Yes, rather than have the contracting rules determine the duration of the study.
We can certainly look at that.
I've no further questions for Dr. Lester at this time. Do members of the board have any questions?
Thank you very much, Dr. Lester. I realise it's been a very long morning for you. I just have a few questions, which I'm sure you won't have too much difficulty with. I mean, you are at state level, in essence, the champion of the people's health in Victoria.
That's right, yes.
Do you think, and thinking back to your days as a medical officer, there ought to actually be someone who is championing the health of the Trope Valley in a supportive role to, I suppose, your role, but I mean, should there be someone who thinks and feels and communicates about the health of the people of Latrobe Valley?
Just to comment on your first point, Professor Catford, is I take my responsibilities extremely seriously as the champion of the health of the people of Victoria. The department is run on quite a centralised model, as you heard Professor Brooks say yesterday. But we do have health officers in each of the 8 departmental regions. So we have staff in the region for the very purpose of them understanding what the particular health issues of the community are. So although there is not a whole team of people who would have the expertise, the epidemiological expertise and the public health medical expertise sitting in the region, we do have our staff in the region who are able to advocate for the health of the people in the region, whatever region it might be it Latrobe Valley or anywhere else, and provide us with the information that we need to address those health risks. As I said, we do have the more technical expertise centralised in the Lonsdale Street office.
And I suppose the point here is I'm not sure the Latrobe Valley community would know who that person was or necessarily feel able to speak to that person or communicate with that person about their health concerns and potentially get some answers. Would that be fair?
A couple of things about that. I receive a lot of emails through my Chief Health Officer email box from members of the public asking about their health, and I always respond to each of those. You've seen in the information that our Environmental Health Unit has a 1300 number, and my staff will always speak individually to people who ring inquiring about their health. And of course the other units such as communicable diseases and immunisation have exactly the same setup, so people can ring and ask specific questions of the staff.
Yes, I mean, I absolutely accept that, and it's a very good service. I'm really thinking about, who is worrying about the health of the Latrobe Valley? Who is their advocate for improvements in health and well-being? I mean, how is that localised in a way that people will have trust and confidence there is someone looking out for their best interests?
Well, I'm certainly concerned about the health of the people of the Latrobe Valley. But I don't live there, I live in Melbourne. As well as the departmental office that I've mentioned, of course, the health professionals serving the people of the Latrobe Valley, so the general practitioners, the community health centre, the local hospital, I would expect them to be the champions of the health of the people of the Latrobe Valley, and anything that we were not able to detect through our regular surveillance systems, both our surveillance systems for non-communicable disease, our surveillance systems for communicable disease, all of our other surveillance systems, if there were things which were happening which were not, we were not detecting, well, I would expect that that the local health service providers would be the champions of their health. The general practitioners have currently what's known as, well, it's not just the general practitioners, it's all primary health services, are coordinated through Medicare locals. So if there is a voice to come back to us, it would obviously be ideal if that was through Medicare locals. But of course, if individual medical practitioners bring anything to my attention or to my staff's attention, then we would certainly take that very seriously.
So, I mean, just finally on this point, I mean, do you think that champion exists at the moment, and is it a function that's being performed well?
I think that our staff in the regional office are very competent and have got very good networks with the local health providers. So although I can't personally identify a particular champion amongst the local health providers, which is not surprising given that I deal statewide, I suppose I can't really answer that question, but I have great confidence in the staff in the department's regional office.
Thank you very much. Now, we heard yesterday, we introduced into evidence a booklet produced by the Californian authorities which is Exhibit 37. Now, I don't know if you're familiar with this, but it seems to me quite a useful resource for public health officials, for the community, for agencies. And I just wondered whether you feel something like this could be helpful for the future in providing more information, essentially, to people about how to manage the consequences of bushfires and potentially coal mine fires.
I'm aware of this document. I haven't read it in detail. I was advised by my staff that this document provided the basis for our bushfire smoke and your health joint protocol with the EPA, but I'm not aware personally of the details in this.
I suppose the point is really, do you think there's a need for more fuller information for the public and for medical practitioners and others looking towards the future? The whole purpose of this inquiry, of course, is to learn and to build greater capacity for the future. Do you think we could improve our resources in that sort of way?
Look, I think we could improve our information and the awareness of medical practitioners about the health effects of smoke. I think as the evidence has increased over the past 5 or 6 years, particularly about PM2.5, I think people are now becoming more aware of the health effects of PM2.5 and the seriousness with which we take our air quality standards. So I think that that's perhaps something that the local general practitioner doesn't appreciate as well as he or she might. So that's something we should take on board and make sure that we do communicate that as we go forward.
Thank you. Now, one of the things that came out yesterday was about the need for rapid air monitoring to assist you and your colleagues. And it'd be interesting to know what you feel about that. Clearly there is a gap in the current system, and part of the difficulties you faced was not actually having access to indicative information very early on in this process. So, would you welcome an enhanced service of that sort?
Absolutely. We would welcome much more definitive data as early as possible in an incident. As we said, we rely on the data and the evidence to inform our decision making. So the sooner we can get definitive data, the better advice we're able to give to the community.
In some ways, one could also look at this in terms of what is the situation now and perhaps a look back, but also some projections or modelling capacity about where these smoke plumes could hit, what the concentration of the particulates could be, very much in the way that I think we're impressed with the CFA's capacity in terms of predicting bushfire spread. Would this be another tool, basically, that could help you if you had better predictive information?
The event that we've just seen was, as other witnesses have said, was really unprecedented. We haven't had an incident like this where a coal mine fire has burnt adjacent to a community. So this was really something which was really unpredictable. I think predicting the next major incident, it'd be wonderful if we had no more major incidents. I think that's very difficult. The initial discussions we've had with the EPA in terms of how we can improve going forward, we have the bushfire smoke and your health protocol. We've been working with the EPA in recent years on planned burns and information about protection of your health from planned burns. We thought that we should maybe expand the bushfire health and bushfire smoke and your health protocol into a more encompassing protocol which has several chapters. So bushfire smoke, planned burn smoke, smoke from perhaps chemical fires as well as smoke from coal fires, so that we have an existing agreed set of protocols prior to any of those particular incidents.
One of the difficulties we face with this particular episode is that people were living so close to this open coal mine.
Yes.
Do you think people are living too close here in Morwell to the mine? And do you have a view about appropriate buffer zones?
I don't have a view on that. I just come back to the fact that this was really unprecedented, something I don't think could possibly have been foreseen, that will wasn't foreseen that this was such a large fire which would burn for such a long time at such intensity next to a town. But the answer is no. I don't have any preformed views about buffer zones.
I mean, is this something that perhaps we should be thinking about? I mean, not least for places where vulnerable people might congregate, whether it's early learning centres or aged care homes. Should they be so close to an open coal mine?
I think it's something it would be very well worth giving some thought to.
Now, this has been an enormous learning experience for everybody, not least you and your team. And obviously, in a situation like this, I mean, you're using your very best resources and all your professional expertise, but we're all learning from this process, and of course, this is why we have the inquiry. So, what are the particular things that you will be thinking about now, moving forwards, in terms of managing an event like this, or other events that might have some similarities in terms of smoke or the long-term impact, or engaging more effectively with communities? I mean, are there particular things that are high on your sort of action list?
Communication is a big issue. That's something which has been extensively discussed. We had, as you will see from my witness statement, the various sorts of communication activities which we undertook, which we felt we engaged a large variety of means of communication. The community has fed back to us that some people did not hear the messages, some people did not understand the messages. So we need to go back and do a thorough review of our communication strategy, and we obviously welcome this inquiry as to informing that, as to how we can best tailor the messages to the community.
Yes, I mean, it's obviously a very challenging situation in a crisis situation with a community that, has seen problems in the past, perhaps, will be more distrustful of agencies, as we've heard in the evidence. So taking that extra mile, that extra step to engage. I mean, so particularly in the engagement activities, I mean, are there more things that we could be doing to engage more effectively with communities like Latrobe?
I think, as Professor Brooks said yesterday, it's very important that communication be done through local channels and the community engagement be done through the local levels. And identifying local community champions better is something I think we need to think about, and making sure as far as possible that those local people on the ground are interpreting and delivering the message as consistently and as accurately as they can.
So particularly in the health sector, we have such people in the form of doctors and nurses and pharmacists and others who are very locally engaged on a day-to-day basis that could form a very good resource for you and your colleagues in terms of keeping the public informed and building their confidence in the measures you might be advising.
Yes, that's right.
Thank you very much.
If the board pleases, I have some questions of the doctor, but in view of the time, is it more convenient to commence those after we resume? I estimate it would take something in the vicinity of 15 minutes.
So whether we have an hour from when you finish or when you first stop now?
For what it's worth, we have no questions of Professor Campbell, and a community witness may not be terribly long, so if that helps in planning of the afternoon, we offer that. Personally, I'd like to commence after, if that suits.
Sure.
Thank you.